Yeah, live.
Good evening, everyone.
Good evening.
So we are back to yet another Wednesday webinar, and it is my pleasure to welcome you all for today's webinar on complex cataract challenges. This is with the Buldhana Ophthalmic Surgeons Society. So we have with us the team boss with the president Dr. Surekha Madam and secretary Dr. Praful Dhake sir. Uh, we are delighted to have with us the distinguished national guest speakers for today's webinar, Dr. Deepak Meghu sir. He'll be joining shortly, and Dr. Shamanta Shetty sir. We also have eminent chairpersons, Dr. Subhash Joshi sir, and respected Dr. Anil Harwani sir, Dr. Shirish Thorat sir, and Dr. Ashish Thul sir. And today's session will be moderated by the dynamic duo, Dr. Saurabh Budra and Dr. Anupam Bagri. We will also have the expert panelists, Dr. Rajesh Joshi sir, Dr. Subodh Purohit, Dr. Sandeep Mangantiwar, Dr. Bhagyashree Deshmukh madam, and Dr. Yogesh Jipkate. So for some unavoidable reasons, Dr. Sean is unable to join today. I express my sincere gratitude to our president, Dr. Viral Shah sir, and the entire team of VOS for their constant encouragement and guidance, which is the driving force for all these academic endeavors. So I hereby request President Dr. Viral sir for his opening remarks.
Good evening, everyone. Am I audible, Rahul?
Yes, sir. Very well audible, sir.
Yeah, thank you. So good evening, everyone. Welcome to this VOS Wednesday webinar. This is the sixth webinar in our series. And today's topic is complex cataract challenges. We are holding this in association with Buldhana Ophthalmic Surgeons Society. So thank you to President of BOS, Surekha Madam, Secretary Praful Dhake, and the entire team of BOS for collaboration. I welcome our guest speaker for today, Dr. Deepak Meghu sir and Dr. Shaman Shetty sir. Before we start with our webinar, exactly 1 month from now, we will be having our VOS Golden Jubilee GoldCon conference in Nagpur, 10th and 11th January. 9th is our pre-conference day. Everyone is invited there. Please join us for the Golden Jubilee celebrations at Nagpur. And thank you so much to the scientific committee, especially Chairman Dr. Rahul Tiwari, for conceptualizing and making it happen, these webinars. Thank you so much. Welcome to all the chairpersons, moderators, and our own local faculties also, Dr. Manish Wankhede and Dr. Shailesh Chhajed. Thank you so much, Rahul. Over to you.
Thank you, sir. We have with us, before we start the scientific session, I request the president of BOS, Dr. Surekha Madam, to have her 2 words to address today's webinar. Madam, you have to unmute, please. Madam, you are still muted. Kindly unmute your device.
Mic शुरू करा मैडम mic.
Yes.
Now started, no? You can
Yeah,
hear?
Yes.
Okay. Respected President of Vidarbha Ophthalmic Society, Dr. Viral Shah, Secretary Dr. Shamik Mukadam, Treasurer Dalankar, esteemed panelists, moderators, and our distinguished national faculties, Dr. Meghur sir and Dr. Shetty sir, and our own boss speakers, Dr. Manish and Dr. Shailesh. A very good morning, a good evening to all of you. It is truly an honor for Buldhana Ophthalmic Surgeons Society to join hands with Vidarbha Ophthalmic Society for this academic collaboration. Today's combined webinar is a reflection of what our profession stands for: shared knowledge, mutual respect, and a collective commitment to serve our patients better. At a time when technology, protocol, and expectation in the eye care are evolving rapidly, such academic platforms become powerful bridge. They help us not only to stay updated, but also stay united. The presence of national stalwarts like Dr. Meghur sir and Dr. Shetty sir elevates today's session to another level. And we are truly grateful for their time and expertise. I also appreciate our boss speakers, Dr. Manish and Shailesh, for representing our society with enthusiasm and academic strength. I thank VOS, especially President Viral Shah sir, Secretary Mukadam sir, and Treasurer Dalankar for joining hands with us. Such partnership nurture harmony and encourage growth in our fraternity. Let us make today's webinar not just a scientific session, but a collaboration, a celebration of collaboration. Thank you and wishing everyone enriching learning experience. Thank you.
Thank you, madam. Before wasting further time, over to the moderators and chairpersons for conducting the scientific session. Over to you, Saurabh and Anupam and respected chairpersons.
Thank you, sir. Thank you.
So on behalf of VOS, I extend my heartiest welcome to all our distinguished national speakers. And we are truly honored to have such an esteemed panel of national speakers as well as panelists both. So we are very thankful for all of you to grace this occasion. I request all the panelists to please occupy their chair. First, we invite chairpersons, Dr. Subhash Joshi sir and Anil Agrawani sir.
Yeah.
Then co-chairpersons, Dr. Shirish Thorat sir, our ex-MOS president, Ashish Thul sir. Moderator, I will be there along with my colleague, Dr. Anupam Bagri. I invite him also to please join the chair. And I now request all the panelists to please occupy their chair. Dr. Rajesh Joshi sir, Dr. Subodh Purohit sir, Dr. Sandeep Mungantiwar sir, my colleagues, Dr. Bhagyashri Deshmukh and Dr. Yogesh Jipkate. So with this, we start our first session. The topics will be the phacoemulsification in post-trabeculectomies eye. It will be by Dr. Manish Wankhede, and he will be giving his expert views. Over to you, Dr. Manish.
Thank you, sir. I, at the onset, thank VOS for giving us an opportunity to present my talk. I will be sharing my screen. Is it visible now?
Visible.
Hello, everyone. Myself, Dr.
Yes,
Manish Wankhede.
Dr. Manish, it's very well visible. And I hope I also request all the audience to please type in the whatever questions you have in the chat box. We'll take it at the end of the session one by one. So keep typing in the chat box.
My video has inbuilt audio in it.
At Khamgaon.
Is it audible?
And today we will be discussing the cataract with the glaucoma.
Yes.
And these two diseases are generally coexistent with each other. There can be various kinds of management like cataract surgery doing alone with the anti-glaucoma medication, doing trap first and then doing the trap next after the cataract surgery. But in all the scenario, today we will focus on a cataract surgery after primary trabeculectomy. And this increases the risk of cataract formation after the primary trap in nearly 78% of the cases. And the complicated glaucoma and cataract course can increase the risk of cataract formation further. However, the early cataract surgery generally helps in early visual rehabilitation and better management of the glaucoma, reducing the cataract surgery complications. However, the cataract surgery can also causes and high chances of the bleb failure and increasing the need of anti-glaucoma medication. So, balancing between the both is the objective while planning the cases of cataract surgery in post-trabeculectomy eyes. Challenges are routine like low corneal endothelial count, poor pupillary dilation, high risk of zonular weakness and posterior capsule tear and other complications, post-operative uveitis. The cataract surgery overall reduces the IOP and need of AGM, but it is totally not true in post-trabeculectomy eyes. In post-trab eyes, post-cataract surgery, the chances of IOP spike are high and chances of bleb failure are also increases. The risk of bleb failure further increases when the patient pre-operatively, pre-trabeculectomy sites have a complicated glaucoma course. So, it is always better to wait at least a 6 months before planning for any cataract surgery. and waiting after 1 year is same result. It doesn't affect much. For IOL power calculation, there are high risk of the myopic surprise, and generally if the toricity is not high, we can avoid a toric IOL. The IOL choice is always a monofocal single piece hydrophobic IOL. However, if there is a high toricity, we can plan a toric IOL but with guarded prognosis. Detailed preoperative evaluation, including the evaluation of the blade, evaluation of the optic disc, visual field functioning, documenting each and everything, IOP monitoring, documentations of a cornea health, pupillary dilation and zonular support and cataract grade is important. The topical anesthesia is the choice. However, peribulbar anesthesia with minimal massage and subtenon is no. We can't operate in under subtenon anesthesia. So this is the one case I will like to share. And this is the middle-aged female who got operated for a cataract trabeculectomy nearly 5 years before, and now she has a cataract. After doing a routine procedure, coating the cornea well with the double soft shield technique, we can proceed further taking all necessary precautions while operating the cataract. My preferred choice of cataract management here is direct chop, maybe because I am very well versed with the technique. But any technique with which the patient surgeon is comfortable is useful. The main goal is avoiding the trauma to the cornea, taking care of the zonular weakness, taking care that there are the chances of a fluid misdirection through the site of trab, from where there is always a zonular weakness and the fluid may get misdirected into vitreous cavity, further increasing the laxity of the bag and further increasing the chances of posterior capsular tear by tenting or pushing forward the PC. So we need a minimal iris handling and gentle pupillary manipulation. Don't be alpha surgeon in such cases. A gentle manipulation. Why there is also a chance of post-operative uveitis in post-trab eyes. So minimal iris and pupillary handling may reduce post-operative complications, including the inflammation, which is the most dreaded complication, because management of the inflammation requires a frequent use of the steroids, which may worsen the glaucoma, and the inflammation may worsen the blade functioning. So even in this situation, like what I am doing, there is a recurrent capturing of iris where the just a PI post-trab has been done, and this iris handling can affect the can cause a more inflammation and affect the inflammation-free eye status. Complete removal of the cortex, complete washing of the viscoelastics which we have put is very much necessary. We want to reduce any kind of inflammation which can affect the blade functioning. Again, a single piece monofocal hydrophobic IOL in the back placement and complete washing of each and every viscoelastic is necessary. Few surgeons prefer a subconjunctival injections of 5-fluorouracil which can be used to maintain a blade functioning. However, I never tried this 5-fluorouracil still in the small experience of mine, and the blade functioning is maintained if we take adequate care while operating the cataract surgery. One practical tip we can access on the table about the health of the blade while staining the capsule. The blade can be get stained, and this gives a fair idea about the blade functioning. Post-operative management is taking care of the blade, keeping close watch of the blade functioning, monitoring the IOP, steroids, cycloplegics to minimize the inflammation, and if we see any early detection of blade failure signs, we can take help of the 5-fluorouracil injections around the blade to maintain the blade functioning. To revise, let's see another case, and the similar the eye which was got operated for the trabeculectomy before few years, and this is a little bit hard case, hard cataract NS3, nucleus sclerosis grade 3 is the cataract, and the similar procedure was followed, coating of the cornea to minimize the corneal endothelial damage, soft and gentle chopping and phacoemulsification Smooth rotation of the lens fragments to minimize the trauma to the zonules, keeping a close watch over the IOP while operating, that is intraoperative IOP inside the anterior chamber, so that the excess of fluid won't get behind the zonules, through the zonules behind the capsule, and we can manage a zonular laxity and posterior capsule laxity simultaneously. We have to keep a close watch that there is no shallowing of the anterior chamber, because such shallowing can affect complicate the further course, and these eyes sometimes may land up in even choroidal detachment if there is sudden shallowing, as there is only a trap which is functioning there. So again, a complete removal of the cortex. In summary, delay the cataract surgery by 6 months after the bleb surgery. Minimal corneal and conjunctival and iris and pupillary damage, clear corneal phacoemulsification, and adequate planning. Thank you. Thank you very much.
Thank you. My presentation ends here.
Thank you, Dr. Manish. Thank you very much. We now will be having Dr. Samantha Shetty, sir. So just a brief introduction we'll be starting with. We just give me a second. Yeah. Dr. Samantha Shetty sir is have done his MS and FPRS, and he's a consultant cataract and refractive services at Prasad Netralaya, which is a super specialty eye hospital. He's a member scientific and zonal committee of Karnataka Ophthalmic Society, currently 2026-27. He is chief organizing secretary for Karnataka State Conference 2024. His special interest is oculoplasty, and he is especially involved in training of fellows and trainees in Prasad Netralaya since last 10 years. He has multiple papers, posters, and presentations in various states and national conferences. And he was recently awarded COS Best Poster Award also. So we now proudly invite Dr. Samantha Shetty for his talk, and he will be speaking on Pulse of IOL Exchange. Thank you.
Thank you for the kind introduction, sir. I'll just try to share my PPT. I hope it's full screen and I'm audible. Am I audible?
Yeah, audible.
Yes, sir, it's full screen and audible.
Yeah. I thank Buldhana Ophthalmic Society and Vidarbha Ophthalmic Society for having me here. I thank the chair, the panelists, and the moderators for all your time. Thank you for this invite. I'll just try to demystify a little bit about IOL exchange and explants. So coming to it's a very tricky situation when we want to think about to go and take out an IOL. So when do we actually think about going about it is usually when there is a visual disturbance there. So that is causing either by multifocals or premium lenses, or your IOL placement which has gone wrong, capsular bag issue is present, decentration or tilt of your IOL is there, an end off, or if the patient is totally dissatisfied. So these kind of an major indication may makes us think to remove the IOL. Usually we try to explant a single piece acrylic if there is a dislocation or a decentration of the IOL. Multifocal if it is causing visual aberrations. A 3-piece if it is actually over a rent we have put a 3-piece and then that's actually causing a more incorrect, more giving you a refractive surface. That is the thing when you're going to consider. Refractive indication mainly is like a wrong IOL, mainly is going to be because of a wrong IOL being implanted. So it's very difficult, critical moment for us to explain this, why the whole thing went wrong. Is it like the biometry? Is it like your IOL's A constant, which is the gone wrong? Basically, your whole calculation and the the post-op problem, you'll need to address it. One, if the patient is not having fussy, you can try to get away with glasses. But if it is like a very demanding patient, then you need to consider some options. Either you try to go explant it off, or you can actually plan to to do a corneal surgery, which again you just wait for everything to stabilize and then think of it as an option. Visual disturbance, again, that's mainly because it's causing you a glare, halos, or dysphotopsia. again, mainly which when we see because of a square edge of the IOL, negative dysphotosia because of some lenses also. We can either now that we have two options. Either we can delay, wait for like the thing thinking the patient like in 1-2 months it's going to be all right, or everything's going to be fine. Maybe the patient is going to come to terms with it. Or second, what can go wrong is like by 3-4 months a syndicate starts developing, and then if you want to go and explant it out also, there's again associated more complication. An inappropriate IOL placement happens when there is a PC tear. So that is when you are going to place an IOL in the sulcus. So either this is going to cause an inflammation or the size of the IOL, especially if there is like a haptic optic size malfunction that can cause. So now either in this situation, you can try to reposition it or you try to explant it off. Dislocation or decentration is the main, like most common. IOL is like one is in the bag and one is in the sulcus, or if it is not like correctly centered out when you have placed it, or you actually put a damaged haptic. So now either like you can same as in this thing, we can try to secure it, reposition it, or you try to explant the whole thing itself. Mainly now we need to evaluate the situation. We need to see like when actually the surgeries happen and how much time you have right now and when the problem is actually started. See the visual symptoms, what the patient is coming with. The reduced vision, is it like more of distorted images, glare halos, double vision, or is basically like premium IOLs which has been put and is causing discomfort too. In evaluation, try to see like when it is, that's what your refractive error has started. You again check your bang on. You don't, if you're going to plan anything for the second time, you need to make sure your refraction is all right. See for your slit lamp examination for the capsule status. If at all you need to go, if there is like any YAG has been done or any tear has been there or calcification is there, it's always better that you have a pre-idea of this. See for the IOL position also, whether there is decentration, tilting, or it's totally dislocated. The other examination, it would be helpful if you get an OCT and assess if there is macular edema or anything. Topography to see any corneal astigmatism. A scan again to just see the axial length of the eye if it is giving you any surprise. UBM or something if to see an IOL dislocation or IOL decentration is there. Always do a risk assessment. One, to see the patient satisfaction score. You have to discuss the visual outcomes. What is does the patient want? How your next what you're going to do is going to influence the outcome of it. You need to explain the risk, like what can happen and go wrong also when you're going to plan for an explant or an exchange. Timing. The more earlier it is, it always gives you a better edge. The more later, it is going to be slightly tricky, like how you have to proceed. Always see your retina before you proceed, and the intraoperative and the postoperative challenges are also has to be kept in mind. Coming to our management, it's simple, like we can keep some strategies how we want to go about it. One is the say you make like a 6 mm normal incision and try to take out the whole thing, do a vitrectomy, and you can try to go with a claw or a secondary IOL. You can try to do the, I'll just show one by one. This is a video by Dr. Uday Devgan. So this is where like he's actually extended your phaco wound little bit, and he's trying to get the IOL into the anterior chambers, put some viscoat into it, and try to twist it and remove it through the same incision. This is his technique of what it is in the textbook. The second, which commonly, which another like a normal person he can try to do is like you try to free the existing oil from the capsule, and then you can use your viscous and dispersive OVDs. Once it is your freed it up, you can try to get it into the anterior chamber and try to take it up. This is one case where like the retina surgery is being done. The oil is they have taken it out, but still a small amount of oil is still left. So now this is caused like your IOL glistening to be happening. So this is one of the indication where like you're going to plan to take out the IOL. Now what we can do is just go take the whole thing out, do a clean vitrectomy and go about it. Or what you can try to do is slightly you try to use a pull and push method, try to get your haptics out. Once the haptics are out, even if the synechiae is formed, just try to push and pull the haptics. It will loosen up. Most of the times it loosen out. Once like if you have loosen out and you got it into the anterior chamber, it's an easy method like which you can even use your Vanus and cut it into 2/3. You don't need to, you can otherwise you try to completely cut it into 2 halves. or multiple again extra halves, or cut 2/3, slightly enlarge your inner lips, and you can just pull it out. Since nothing much has been compromised here, I still have intact sulcus, so I'm still going ahead with the 3 piece and going and finishing the case. Second is, this is like a case of multifocal, where this is causing a lot of glare and halos to the patient, and patient is basically uncomfortable with it and opts to get rid of it. Earlier you plan, that is like before 3 months, if you're planning it, you always have an edge to remove the haptics very easily. The more than 3 months, what happens once the synechiae starts happening, it becomes very tricky. If it is too stuck, when you're trying to pull, the whole back and loosen out, or your zonals can get compromised, that becomes like a lot of problematic thing. So here, that's what you have seen me try to try to loosen out the haptics. Once that is done, you remove it and you try to go again put with the normal monofocal IOL. Cutting the IOL. So cutting, when you're going to cut the IOL, there are like 2-3 things which you need to keep in mind. Always like try to use your dispersive visco up and below the thing. First, always as you free the haptics, you can use your IOL cutting scissors, Vannas, or IOL cutting forceps. You can cut it into 2 halves and remove, or you can cut it into 2/3 and then just the inner lip of your phaco wound of 2.8 incision. You can just the inner lip, if you extend it, it's still more easier. This is like a plate haptic. I'm just going to show more of videos. This is like a plate haptic lens which is put, but it was cut. So since a damaged IOL is already been put, the patient is now experiencing diplopia. So in these kind of cases, since like this is almost like 2 months past the surgery. So my thing, what I'm going to keep in mind is, since like the pupil is also not dilating too much, now it's very limited options for me. One, you try to slowly try to get the whole lens into the anterior chamber, and then assess like your PC, how it is intact, is there any other problems, zonals are weak, and then go ahead. If everything is fine, then you can try to just normally explant the IOL and then again go ahead with another good IOL. Here what you're seeing me see, like I'm just trying to slowly, without much manipulation, trying to get the IOL into the AC. We are seeing like the below half of your entire haptics has been cut off. Now what I'm trying to do is just like you're seeing the inner lip, I'm extending it and trying to cut, basically giving a nick to the IOL. Once that is done, I can try to push and pull technique just to remove the entire IOL. Or again, I have another option. My plan B is going to be to cut the entire thing into 2 halves and then remove it. You have to be very careful, like how you're handling the tissues here. Always better, that's as I said, like use the dispersive visco. See, you're just like I'm just pulling and with my forceps, and it was very easily to remove. Since my PC is still intact and it is not compromised, I can still go ahead again with another monofocal lens and just close the case. This is again, I'm just showing with if you are not having any extra special instruments, with your same Vannas only, you can just cut it into 2/3. Just as I said, like your inner lip little bit, if you extend, it gives you a better edge. I'm just using my dialer as a support system there. Refolding technique, this is again like a technique which is used by Dr. Uday Devgan. Theoretically, it is there and his videos are there. I have not used it. This is basically an acrylic IOL which he's folded and he's taken out through it. This is also one of the other methods which you can try to implement. So that is the same thing, but yeah, you need to increase your wound to 3 to 3.5 incision for this. This is like coming to, I'm just going to touch upon a new future. This is like, an IOL cutter which is actually designed by Dr. Neha Dolakia. This is in the market. This, what happens is, this probe which you just have to fix it to your phaco probe. Then when you just press the foot pedal, that does the rest of cutting it into a little multiple pieces. So for this you don't even again need to extend it or do any circus. This becomes much more easier for anterior segment surgeons to proceed easily. And then again, the another help of this is like you can even try to Even if you have a very black cataract, you can just make the initial trench and divide it into like 2 parts, and then follow it up with your next part of the surgery. To summarize, you always have to weigh in like the factors influencing your decision. Always keep your patient visual expectation in check. Always assess your safety margins and timing when you have to go about it. To conclude, prefer always the existing IOL to be repositioned. Give always a realistic expectation. Refractive IOL, if you are planning to exchange it, it's better always you do within the first 3 months. The most difficult part about an exchange is to free the haptics. Always, thread carefully where your bag is compromised, and choose best technique accordingly to the situation. Thank you, and I thank everyone for your patient listening. Thank you so much.
Nice.
Thank you, Dr. Samant. Thank you very much. We will just take a few experts' comments and 2-3 questions in next 5 minutes before we jump to the next session.
Yeah.
I invite Dr. Ashish Thul sir for his expert comment on Dr. Manish video. If you have any suggestion, comments, or anything.
Dr. Ashish sir is not yet there.
Okay, so
I
Dr.
think
Subhash Joshi sir and Anil Arvani sir, you would like to say something? Dr. Sandeep
Dr.
Mungantiwar
Manish.
sir?
Yes,
Dr. Manish,
yes.
Dr. Manish, how do you feel the chances of malignant glaucoma in post-trabeculectomy eyes after cataract surgery? Do you feel that these are more as compared to other?
Yes, of
Because
course, sir.
there are always chances. Because there are chances that your fluid may go behind in the posterior segment to the vitreous.
Yes, sir. There are always the chances of malignant glaucoma in such eyes because there is already a well-functioning bleb is there if it is present and functioning, and sudden fluctuation of intraocular pressure in such cases can causes a misdirection and misdirection of the fluid, and chances of malignant glaucoma are very high. But fortunately, since last 10 to 15 cases, I didn't came across this situation.
One more thing.
Sir,
Yeah.
to control, I tried to give intraoperative preoperative mannitol in few patients, but over the period, I thought it is not useful to go do with this intervention,
going to be
and
useful,
routine
yeah.
surgery is still now working well, but just a low IOP phaco is very much necessary.
And do you have, did you had any cases of post-operative shallow AC because of the over-filtering of the blade after cataract surgery, or?
Yes,
no, sir.
even I
blade
will
is
have the
already
same
there.
question. And how will you manage the case if suppose you have you have a shallow AC post bleb surgery?
Post-operative, yeah.
Sir, generally, when we plan the cataract surgery in post-trap cases after 6 months, the bleb has acquired its natural functioning. It is well customized to the normal functioning of the eye, and the IOP fluctuation during cataract surgery from 20 to 40 or 60 mmHg generally doesn't affect or doesn't cause the overfiltration of the bleb. So hypotony in such eyes until and unless there is a fluid misdirection or choroidal detachment is generally not seen, unlike we see in just fresh traps. So old trap cases that I already said that the cataract surgery need to be planned after 6 months so that the bleb gets its natural autonomous functioning. So even if we find a choroidal detachment, then we can go ahead with the systemic steroids. But generally, hypotony due to overfiltration doesn't happen, sir.
Manish,
Yes, sir.
any tip for giving the peribulbar block in trabeculotomy site?
Yes, sir. Currently, I am when we operate such cases when there is an pre-existing hypotony or I have to operate or re-intervene or in a post-trab eyes, I generally found that if we want to give the peribulbar,
Yeah.
I give 2 millimeter of the block, 2 mm of the block at lower part of the orbital margin,
Okay.
and 1 millimeter in medial canthus, and
Okay.
this give a fair amount of the block, and this small amount of injection doesn't require any massage or it doesn't increases the retroorbital pressure also.
Thank you. Thank you,
Two
Manish.
plus one is sufficient.
Excellent. Excellent presentation.
Thank you, Dr. Manish. I now invite Dr. Rajesh Joshi sir and Dr. Subodh Purohit sir for their expert comment on pearls for IOL exchange by Dr. Samantha Shetty. He has shown excellent techniques. So, will you like to add something to it, Dr. Rajesh Joshi sir and Dr. Subodh Purohit sir?
Yeah, it was really a wonderful presentation, Dr. Samant.
Thank you, sir.
In fact, whatever things which are available for IOL exchange, that has been well covered by him. And I have nothing to say. In fact, most of the techniques have been well covered. What I do, I usually bring, usually this happens with breakage of the optic or haptic while insertion of the IOL. So in that case, sometimes you may have to extend the wound to 3.2 millimeter for the proper removal of intraocular lens, because if you try to remove through 2.8 millimeter incision, the incision may get damaged. So that is one thing. And what I do, I bring one of the haptic outside the wound and then cut the optic with the help of long scissor, and in a chair-shaped manner, I remove the entire optic and haptic. That is what I usually do. Otherwise, rest of the things I don't use. And one has to use high molecular weight viscoelastic while removal of the lenses, whatever cause could be.
Thank you, Joshi sir. Dr. Subodh Purohit.
He is not there, it seems.
Okay. Can we take 2-3
Dr.
audience
Shetty,
question, organizers? Can we have some audience question?
Yeah.
Can I
add
ask something
something,
to Dr. Shaman Shetty?
Yes, sir.
Yes, sir.
Yes, sir. Please.
Can I add something?
Dr. Shetty,
Yes, sir.
that was a nice presentation. What is your preferred technique of exchanging the IL space, and does it vary with the material of the IL in hydrophobic and hydrophilic? Do you find any
Sir,
difference in that?
the main thing which I found was like how Rajesh sir was telling. Initially, always we used to think like to extend it and to take it out. It always used to be better. Then once like I started thinking like the same 2.8. The main problem is in your inner lip. The inner lip, like for us to start taking it out now, if that like stretches, that becomes like the first moment. If it comes a little bit easier, then the rest of the things comes easier. So once that what I started then changing was my same 2.8, my inner lip I started extending it. So that even if I'm like using a forceps and trying to pull it up back to back, either that is also helping it out, or even like if I'm cutting it into two parts or two-thirds also and then trying to take it out, the explant happens smoothly. You don't like the time it is like 3.2 or something. Sometimes our wound closure again you will need to put a suture, or any if like again in your topical cases or something, sometimes it becomes tricky. This is what in my this thing I felt. Yeah, like the material wise, sir, like what the video which I showed theoretically by Dr. Uday Devgan, that I have not tried, like either the folding or that, because this was what like I preferred, and most of my cases, like whichever it was fine with this. Material wise, like the first that four haptic one, that was like a hydrophobic, one was an hydrophilic, but hydrophobic is much more easier to remove it.
I just want to add one thing.
Yes, sir.
In continuation with what Dr. Harwani sir has told, I find it very difficult to remove the lenses, broken lenses, particularly with thick haptic, thick optic and the double C-loop haptic. But this is particularly with broken Renner lenses. They have very thick optic, and their size may be a little bit small, but usually they pop up into the anterior chamber, and while removal of these lenses or while cutting of these lenses, it becomes very difficult. This happened with me twice or thrice because they have brought those lenses in a preloaded thing, and it becomes very difficult to inject these lenses. So it happened with me. I don't know what is the experience with other speakers, but I find those lenses to be removed whenever they break very difficult.
Yeah, I have one more addition to it. Actually, what sir said is very right that hydrophilic are very difficult to remove compared to hydrophobic because they are thick. And even the twist and turn technique is easier with hydrophobic lenses because they are thinner than hydrophilic. But I want to ask Dr. Shetty that how does he remove three-piece IOS? That I think those are the most difficult one to tackle because the optic is hard. It's not very easy to cut.
Ma'am, that is like, see, one, like usual, it has always been like, straight do like an 6 millimeter and take it out. Because like to take it
No.
to the
So
haptic
you
has become problematic. Second thing, like right now, I have not tried it actually, but with what Neha ma'am's this thing has come, like the new lens cutter, which we can put it in the probe and you can use it. Our thicker lenses can be cut, but I don't know, like for a three piece, I have not attempted it. The thicker lens, like how like sir said, no, with that phaco probe itself, that itself acts like you're cutting this thing. That's how it's been designed now. To any of your machine, the probe, when you press your foot pedal, it just like cuts through. Even if it is thicker, it is much easier. That cut becomes much better compared to any scissor or anything which is there. Three piece I've not tried, so I think maybe sometime if I try,
maybe.
definitely yes.
Yeah.
Thank you, Dr. Manish and Dr. Samantha Shetty, sir. And because of time constraint, we now move to the next part of our session. I invite my co-moderator, Dr. Anupan Bakri, to take over from here.
Hi. So let's move on to the third talk for today. It will be presented by the young and dynamic Dr. Shailesh Chhajer. He's from Buldhana. He has passed his MS from GR Medical College, Gwalior, and then he went on to do his Ratan Tata Fellowship from Shankar Nethralaya, Chennai. Then he completed his fellowship in comprehensive ophthalmology at Lions Nabai Institute, Miraj. And now he's presently working as director and head of ophthalmic services at Ashirwad Multi-Speciality Hospital, Buldhana. So he will be speaking on the topic, what better can be done in difficult cases. So over to you, Dr. Shailesh.
Yeah, good evening, everyone. Thank you, boss, and all the members for giving me this opportunity. I'm just sharing my screen. Uh, is it visible?
Yes,
hello.
you are visible.
Yeah, okay. The topic, I am just a basic cataract surgeon, and I just want to present a case, and I just want to give my suggestions and definitely suggestion from all the experts so that what can be done to get a better outcome. Yesterday, I saw a thought that I had learned so much from my mistakes. I am thinking of making a few more. This is definitely not our motto because we are here to learn from others' mistakes. So I believe in teaching by self-learning. So I'm presenting my case so that I can learn from my own mistakes and others can also. So presenting a case for a basic cataract surgeon, when you do regular cataracts, I think when you do pseudo exfoliation cases, it is many times a nightmare to find a weak bag on the table. Similarly, presenting case, it's a 72-year female case having a complaint of diminution of vision, left eye since 60 days. She had a tremendous head nodding. Right eye was absolute glaucoma, so she was a one-eyed patient. Left eye, she had a significant cataract with vision of 636. Shallow ACs and pseudo exfoliation was noted at pupillary margins. The pressure was normal. On gonoscopy, I found the angles were close, so I preferred to do a PI, which were uneven. On follow-up, I found that angles were a bit open. Did a dilated examination. There was a 7 mm dilatation, and there was a 360 lenticular PXF. 90D. Luckily, there were no these changes right now. So after complete cataract workup and fitness, I was taken for the surgery. Preoperative, as the pressures were normal, I just preferred to give a Diamox. I didn't prefer to give a Mannitol, an antibiotic, and a normal dilatation. Just I'll proceed the surgery. So initially Rexis, I usually prefer cystotome. Though in such cases, I would suggest if you are well versed, intraocular forceps is a better option. Use intraocular forceps in between wherever I need, and again I completed the rexis with cystotome. During such situations, we always do what we have better control over. So I prefer cystotome. Then after the entry, I found the bag is too weak. So I plan to put a CTR right now, but I thought that the CCC would be a bit smaller. So I thought it is better to extend the CCC right now. I thought it would be better even to manage the nucleus because the dilatation is 7 mm. If it comes down, it is better to have a bigger rexis. Before putting the CTR, I always prefer to separate the bag from the cataract using a iris repositor or so. So this is iris repositor separating the bag. Also, putting the visco between the bag and the cataract helps to put a CTR better, and that it will help to remove the cortex easily at the end. I prefer to manually put the CTR because I'm not very comfortable with the injector part. I use the two-dialer technique to put the CTR. Putting the CTR thought would make the surgery more comfortable. A good hydrodissection is also required so that there are less stress on the zonules during the phaco. So I did a multiple hydrodissection multiple times and just try to rotate the nucleus. The video is 4x, so you will see everything is going very fast. Just I wanted to show every step. I usually do direct chop, but in this case, I prefer to do sculpting and then chop it so that we get a better grip and lesser stress on the zonules. What I usually prefer to bring a piece or so out of the bag so that the bag becomes less stressed and it is easier to manage remaining of the cataract. In this time also, I prefer to come out, put visco, dial the nucleus again. I use a chopper, but for manipulation, it is better to use a dialer. So better safe instrument. Again, need to chop. I change the instrument to a chopper and again use the dialer. I prefer to use my second instrument more to feed the nucleus than moving the phaco probe. Again, using the dialer to maneuver the nucleus so that the phaco probe remains in the center. In a complicated case, we always think something is going to be gone wrong. So it feels like there is a rent. So just to check it, I use again the iris repositor to see if there is any vitreous or just cortex. That is a positor, but everything is okay, seems okay. So I'm going for the INA. Here the problem will be to removing the cortex part. Luckily for this case, it was easier to remove, except for the one quadrant where I tried to loosen it, but it was seems more risky, so I did not remove it. I left it at the end. The cortex here you see is stuck, and I thought it would be more traumatizing, so I just left it. Put a visco. I put a single piece hydrophobic IOL. Again, after putting the lens, now I thought it would be better, easier to loosen up the cortex and now remove it after putting the IOL. So removing the visco also and now removing the remaining cortex. So this is the post-op day 1 picture, and this is the post-8. Studying retrospectively, then I thought what could have been done better, so that it would have been more easier. Few points what I thought would have been better. That CCC, if I could, but intraocular forceps, it would have been more better. Because I would have better rexis, it would have not been needed to extend somewhere. Then what would have been the ideal size for rexis to place a CTR? Was the rexis initially enough, or it was good to extend? A normal 5.5 mm rexis is better, but as 6 mm rexis would have been preferable. What was the right time to insert the CTR? Putting CTR is always a dilemma, to put before the nucleus or after the nucleus, but I think in such cases it is better to put a CTR than land up in having zonal dialysis. So I prefer to put a CTR early whenever I feel the bag is too weak. Was a multi-piece option, a multi-piece IL a better option? I think post-operatively, after thinking, it would have been a better option, but that time it was a thought that it's a smaller bag, a smaller rexis, it would have been difficult to put a multi-piece IL, so I prefer not to complicate the surgery and put the single-piece IL. So take-home message would be only this for a cataract surgeon, that if you prepare better, good preparation, a timely intervention of CTR, keeping calm during surgery. I would always also suggest to watch videos of surgeries before doing such surgeries. I usually watch such videos before such surgeries. Definitely helps us improve surgical. Thank you.
Wonderful presentation, Dr. Shailesh. Looking about the CTR the timing, it reminds me when one of my mentors had mentioned that it should be placed as early as you must and as late as you can. So that is probably how we can think about the timing. And yes, definitely, a lot of questions have been popped up looking at the video. So we can take inputs from. Sir, I would request you to please share your screen where you had put up questions. The slide.
Can I ask something?
Yes, sir, please.
I'm Dr. Anil. Yeah.
Yes.
Shailesh, I wanted to ask, I mean, was the PI done before by someone else and used when you saw the patient, or you did PI before surgery?
Sir, I did PI before surgery.
Why PI was done? I mean, when you have planned a cataract surgery, what was the advantage of doing PI? Because the disadvantage of PI, it was already compromised zonule you were expecting because of pseudo exfoliation and all that. And PI, you must have done YAC PI. That itself would have compromised the zonules more. And what advantage you would have got by doing PI?
So only advantage what I thought when first time I saw the case that AC was too shallow, and I was more afraid that time pseudo exfoliation was only seen in the pupillary margin. I was not really sure to take the patient for the cataract surgery, and I was very afraid to do the dilation. So I planned the PI first. I did the PI. After that, I thought the angles were open. And after a few weeks, I planned now I can go for dilatation. After seeing the dilatation, I thought the zonules are okay, so that I can go for cataract surgery, because it's a one-night patient. And I thought if the zonules would be too weak, I would send it to a retina surgeon for the surgery. That was the only thought in my mind.
Well, okay, fine.
Any other inputs from our chairpersons or panelists? Dr. Joshi, sir, if you have any special comments about
very nicely, very nicely presented, Shailesh, and very well managed. I could have done differently. I would not have extended rexis as you extended, because what happens many times, if it goes towards periphery, then you are nowhere. That is one thing. And I also many times repented and for extending the rexis. That is one thing. And what I do, I usually debulk these lenses before implanting CTR, because what happens when you implant CTR in such cases, there could be zonular capsulocortical adhesions. And while implanting CTR, if suppose the zonule breaks, then there is always a problem. The entire bag may rotate and may cause problem. So ultimately, you may have to convert it to SICS, or may have to hand over the case to vitreoretinal surgeon. And in such cases, I usually prefer multi-piece over single piece,
That I thought, sir.
because that causes stabilization of the zonules as well.
Yes,
So that is my thing. And always look for the intraocular lens power and the axial length for proper sizing of the CTR
Okay.
that
Yes, sir.
you should see for before implanting the CTR.
Yes, sir.
And as far as timing is concerned, there is as such no exact timing. Whenever you think that you are pulling the bag, at that time you can always put, because implanting too early could be a problem, or implanting too late is also a problem. So it's usually by experience you choose the timing of putting CTR. So that is what I think while managing these cases.
Yeah, I had a doubt, sir. If we debulk the nucleus, wouldn't be difficult to place the CTR between the bag? It would be more of like what I prefer. If you put a visco and put a CTR, it would be easier to put a CTR between the bag and the nucleus. So the cortex is less stuck. That was the only idea behind putting the CTR early that time. And it would have been a more stable bag to manage the nucleus because it was a comparatively hard nucleus. So what I thought during maneuvering, it would have been more difficult for me to maneuver the nucleus. That's why I chose to put a CTR early.
Now, what happens when you debulk? Debulk means removal of the cortex. You just
Yes,
remove the cortex so that you get an idea about the nucleus, how much
right.
amount of nucleus is there.
Okay. Yes.
And it creates a space also in the bag. When you debulk the cortex, you create a space between the nucleus and the bag itself. So there are less chances of zonal adhesions when you put the CTR. So that is the idea about the debulking the nucleus. So that you can do in a sculpting mode only.
Yes,
You don't have to put on your chop mode. You just go with low vacuum and wall flow rate.
Yes, sir. Thank you.
Thank you, sir. Thank you so much for all your inputs. In the interest of time, we would like to move ahead with our fourth talk, which is by none other than the famous and dynamic YouTuber, ophthalmic surgeon, Dr. Deepak Megur. He heads the cataract and glaucoma department at Megur Eye Care Center, Bidar, Karnataka, and he specializes in complex cataract surgeries and is very passionate about teaching and sharing his surgical skills through his YouTube channel as well as a website which is called as facotraining.org. And he has a big list of awards and recognitions which he has received over past multiple years at national and international levels. It's not possible to list them all right now. And with this, I would like to hand over the session to Dr. Deepak Megur. He'll be speaking on posterior capsular tear, all is not lost. Over to you, sir.
Yeah, thank you so much for the opportunity. Thank you, the entire team of VOS. Thank you, Viral, and all the organizers. So, how much time do I have?
There's plenty of time, sir.
No. Okay. So I'll just try to give a brief synopsis because PC theory, as you know, it can take a whole day or whole month as well. So I'll try to just give a brief overview of what I'm trying to teach nowadays is like how does the morphology of the PC tear looks like. Just trying to describe the morphology of the PC tear. I think my screen is visible now. So
Yes,
let us ask a very basic question. How does a PC tear look like? When you ask a resident to describe, so initially when if you nowadays we are blessed with the good retroillumination mode, we can actually literally see the margins of the posterior capsular tear. Maybe few years back, PC tear was diagnosed only after the vitreous loss had happened because the vitreous comes in and the dynamics of the chamber changes, and then you diagnose PC tear. But that era is gone now. Now, because of better visualization system which we have, we can diagnose PC tears much early and probably prevent vitreous prolapse as well. So if you can describe how a PC tear, actually you can see a break or a breach where we see two margins of the posterior capsule, say many other times, and many times you can just see one. So let me just take you through how actually the posterior capsule tear looks like. So let me pause here. Let me pause for a second here. If you can see, there is one line here. Hopefully my arrow you're able to see. This is a line. The second line which is seen, and there is a central round ring which is seen. This is what we call as a double ring. And the second ring is actually the anterior hyaloid rupture which has happened. So this is a posterior capsular tear. This is a posterior capsular tear, and this is the central ring is the the anterior rupture there. So we can see in such detail the morphology of the PC. This is again a PC tear. It has a different morphology. We can see three edges. It's a triangular posterior capsular tear. We all know it can come in various sizes and shapes. So in this case, you can see that there is a parallel line split which is there, and in some cases we don't see the other two lines. So classically, we can see whenever see one line or two lines, probably it means that we are seeing a PC tail. Sometimes we see both the lines, and sometimes we may see just one line, as in this case, the other line is hidden in the equator. So we have whenever we see a line in the posterior capsule, be careful about it. It comes in various shapes, and it can be very small, circular. It can be triangular shaped. So it comes in very varied shapes and sizes. So one has to be alert to diagnose it as early as possible. See, the whole goal of us to diagnose early is, if we can diagnose early, the chances of us putting the lens in the bag increase very early. So that's the reason I'm showing you so many PC tears. Okay. The next question would be, does the PC tear always mean vitreous prolapse? Does it mean always vitreous prolapse? That's the question. Well, the answer is no. Okay. It does not mean vitreous prolapse. Thing is, okay, and the next question would be, can we, just looking at the posterior capsular tear, can we distinguish whether the vitreous has come or not? Just looking at the posterior capsular tear. So that is the next question. See, the classical teaching has been you put triamcinolone acetate to identify whether the vitreous is stained or not. Now, before even doing that, just looking at the morphology of the posterior capsular tear, can we distinguish? If so, how? It is possible to distinguish between the vitreous presence and without a vitreous prolapse. So how does a PC tear without vitreous prolapse looks like? The posterior capsular tear defect is very narrow. We can see the two edges which are very narrow to each other. They are not splayed wide open. So this is one situation. You can see this is a round, well-defined. Second, there is no kinking of the margin of the posterior capsules. The edges are well-defined. These are all indicative that it is just the if you can see, there's one more critical sign. This flap which was caught and torn, it was fluttering. So whenever we see the flap is fluttering, the posterior capsule, it again indicates the vitreous is still not come in place and anterior is still intact. Because if the vitreous comes in, what happens? It is a heavy liquid. It just stiffens up the edges of the posterior capsular tear and it stops fluttering. So these are some of the clinical signs which say that so this is a posterior polar cataract, and we can see this is a posterior capsular split which is happening equator to equator. But there's a very narrow gap between these two edges, which is again very much suggestive that the anterior highlight is still intact. So if the edges are very widely stretched or say, then probably it indicates this thing. A narrow gap and straight line, then it indicates a vitreous. How does a PC tear with a vitreous prolapse look like? Let's look at the morphology. You can see the edge of the posterior capsule is very splayed wide open. It's wide open, and more importantly, there's a deformation of the posterior capsular tear margin. Now look here, there is a kink at the posterior capsular tear because the vitreous is trying to find its way across the posterior capsule tear to the side port incision. So this is an indicative that the vitreous is already prolapsed. You don't have to bother putting your triamcinolone acetate. It's already clear cut. Look at this here. Whenever you see the margins of the posterior capsular tear are very fixed and stiff, and they're not flowing, when the fluid is moving around, the BS is moving around, then it indicates that the vitreous is already present. So looking at the margins of the tear, when you see there is a kink, so there's something called as double ring. So what do you mean by double ring? When you see double ring, it indicates that the first ring is of the posterior capsular tear, the second ring is the anterior tear. So you can see this is the posterior capsular tear. The second, one more ring we can see actually, this is the anterior haloid rupture. So if you are very close and meticulous, you can clearly diagnose the presence or absence of an anterior haloid. So how do you confirm it? Okay, now at this stage, the anterior ruptured, but the vitreous is not prolapsed out. The moment I try to put in OVD, the OVD displaces the vitreous, it prolapses out, and it is rushing towards the side port incision. Now you can see the classical kink which I was referring to. So this was before the vitreous prolapsed out, but just the anterior rupture. When the vitreous has come in above the level of posterior capsule, it deforms the posterior capsular tear. So this is another case, this is a posterior capsular tear, and the second one, what we see is the anterior haloid rupture. So the message here is that if we are very alert, this is one example. I'm just trying to push a little bit of a hydropolish. There's a posterior capsular tear develops. I continue to irrigate, and as I continue to irrigate, you can see there is a second ring which appears. The first was the posterior capsular tear, second was the anterior haloid rupture. So the message here is that PC tear and anterior haloid rupture are two independent entities. The first is the PC tear. If I'd stopped here now, I could have prevented the anterior rupture. So I got a couple of seconds time and I ignored this sign and I continued to irrigate. And what happens? The second ring appears. Now this is the anterior rupture. So with this, I think I just wanted to give you a message that if you're very alert and if you can diagnose PC tear early enough, then probably, many times you would be lucky enough to prevent vitreous prolapse and doing a vitrectomy. And what it does is it increases the chances of us placing the originally planned lens into the bag. So that's the reason why I want all of you to get sensitized to the fact that if you can diagnose PC tear early, and thankfully we can do so because of the excellent red glow nowadays which we have with our microscopes, it's very much possible to diagnose the tears much more earlier. And in almost 50% of the cases, if you can pick them up early, you can minimize or prevent the rupture of anterior haloid. Now, moving on to the next talk, which is, can we minimize the enlargement of a posterior capsular tear during anterior vitrectomy? See, past plan approach has been advocated of late by Dr. Basavda and Dr. Chang. The goal was by doing through the past plan approach, we can reduce the chances of the posterior capsular tear enlargement. If you can reduce the PC tear enlargement, then we can place the lens in the back. That is the goal. Now, my question here would be, can we achieve similar goal by going through the limbal route itself? Because going through the past pana, many of the anti-segment surgeons might not be comfortable with. So can we achieve similar results using an anterior limbal route? So let me take you through a few cases here and just try to demonstrate, like if you follow certain principles, we can achieve this. The first goal whenever you suspect a posterior capsular tear is prevent the antechamber from shallowing. If the antechamber suddenly is shallows, then the anterior ruptures or the PC tear enlarges. The first reason why the PC tear enlarges is when the chamber shallows, the vitreous comes forward and it enlarges the PC. The moment you diagnose a PC tear intraoperatively, first thing is don't come out, inject OVD inside the eye so that the chamber does not shallow. This is the first rule to follow. And then visualize the extent of the posterior capsular tear. Now, as you're trying to put OVD, you're trying to visualize the extent of the posterior capsular tear. The second most important principle, which not highlighted very often or not taught often, is what you do is you have to decrease the infusion pressure, decrease the bottle height. See, suppose if when you're doing a cortex aspiration, your bottle height is at 80 centimeters or 90 centimeters. And when you begin vitrectomy, if you keep the bottle height at 90 centimeters, before even starting your vitrectomy cutter, the moment infusion goes in, the pressure itself will load the posterior capsule. So remember, the first goal is to decrease the infusion pressure. See, when you suddenly raise the infusion pressure, you can see the chamber suddenly deepens and the fluid gushes inside, and this itself will load the posterior capsule. The next is, I would want to propose a new principle, what we call as segmenting the prolapsed vitreous into two parts. So this is, what you see is basically you're going to place the cutter below the posterior capsule and begin cutting so that you're cutting the vitreous and dividing into two parts. One is below the posterior capsule. The other one is the prolapsed vitreous, which is above the posterior capsule. By doing so and dealing with them independently, the chances of enlarging the posterior capsular tear during this maneuver is minimized. So this is the principle which I would want to explain it here. So this is what I call as dividing the vitreous into two parts. Now this is a case where the vitreous has prolapsed, PC tear is there. So we want to ensure that we don't enlarge this PC tear during our vitrectomy process, so that the lens could be placed in the back. That is the primary goal here. So whenever we are already put in OVD before we come out. So when you stain, staining doesn't happen because it gets mixed with it, and you cannot really identify the vitreous properly. You can see a few strands here which are come here. So let me just highlight the settings here. Cut rate is very high, flow rate is very low, 10, vacuum is 350 or you can still less. Most importantly, please note the bottle light is kept at 28 centimeters. That's the highlight feature. So don't go with the high bottle light. The chamber is already filled with OVD. If you go with this thing, it goes on. Now look at the position of my cutter. The cutter is placed below the posterior capsular tear with the bevel facing posteriorly. It is held stationary as the cutting is begun. Not doing anything, just not moving around anything. Just stay still, cut across the portion. And once you are sure that a reasonable amount of vitrectomy has been done, you're just below the level of vitrectomy. You don't have to be very aggressive and remove a lot of vitreous, just a little bit. After doing that, then your bevel is turned sideways first and then anteriorly. And now you're dealing with the vitreous which is above the level of the posterior capsular tear. So by doing so, you are minimizing the chance, we are not dragging on the vitreous. So that if the vitreous comes out, it's going to enlarge the vitreous. That we are preventing by using this maneuver. Once you're certain that the vitreous is taken care of, now is the time to deal with the cortex. Remember that whenever there is a vitreous prolapse, it is like God. It has to be given the first and primary attention. Forget about nuclear material, forget about your cortex. First deal with the vitreous properly and then take care of the cortex. And then I used a sodium hyaluronate, created the bag, inflated the bag, and I could place the lens into the bag very comfortably. See, our goal was achieved that we did not enlarge the posterior capsular tear. Now, this is the next case where the PC tear and the anterior rupture has happened. Now, we can see that there is this kink here in this because the vitreous is now prolapsed out. Now, during vitrectomy, there is every chance that this can enlarge and cause and prevent us from placing the lens into the bag. So now our goal is to do the vitrectomy to ensure that this does not enlarge. So again, the same principle has to be followed. So again, you can see the morphology of PC tear clearly indicative that where the vitreous is heading through. So you put in a little bit, always try to do a cut the vitreous which is prolapsed out of the eye. Begin by doing so. And again, look at the bottle light. It's kept as low as possible in 20 centimeters. And then look at the position of the bevel. The bevel is placed posteriorly below the level of the posterior capsular tear, and then the cutting is begun. So the idea is first you're trying to cut the vitreous which is below the level of the posterior capsular tear, by hoping so that the bridge between the prolapsed vitreous and the one which is below is cut off. And once that is done, you're going to turn the cutter sideways first. And if you feel that the chamber is shallowing, that's the time you can increase the bottlet gradually. And once the vitrectomy is done, before enlarging, you can see the tear has not enlarged. So now, before implanting the lens, in this case, I'm doing a posterior capsular rhexis, simply because even while putting the lens, the haptic of the lens itself can tug at the margin and enlarge the tear of the rhexis of the posterior capsular tear. That's the reason why we need to and do a rhexis before that. So if you're comfortable doing a pass plan approach, it also is good enough. My recommendation is rather than using a trocar cannula, you can just use the MVR blade itself, directly measure 3 millimeter from the limbus and enter through and through. Infusion is from your anterior port and measure 3 millimeter, use a MVR blade, directly go in. And again, the principles are going to be the same. Don't cut as you enter. You go in, position your cutter where you want, direct visualization is there, and then start the cutting. It is not a very difficult technically, but you can very well do it as well. But what I feel is if you follow the right principles, you can achieve similar goals even with the limbal approach. So with that, I think I'd like to conclude my presentation. Thank you once again for the opportunity.
Anupam, are you there?
Yes, sir. Thank you so much, Dr. Meghur. As always, the presentation was wonderful. So crystal clear images and videos I wonder what level of cameras and microscopes we'll have to use to identify the double ring sign well in advance. Uh, and so, any inputs regarding these concepts from the panelists or chairpersons? We can take a short 2-minute time to address the inputs, and then we can move ahead with the program.
Excellent presentation, Dr. Mehur sir. And we really respect your feelings that Vitreous is a god. It should be given first honor. We'll follow that, and we'll follow your tips also. Thank you, sir. Thank you for nice presentation. No need to add anything. We are just followers of you.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
And as we come to the end of our program, I would request Dr. Shamik Mukadam to come up with some words of gratitude.
Thank you, Anupam. Good evening, everyone. At the outset, Rahul, thank you very much for an excellent curated program today. This was our 6th webinar, Wednesday webinar, and it was on complex cataract surgeries. On behalf of VOS, we are grateful to our esteemed national faculty, Dr. Megur sir and Dr. Samant Setti sir, for their insightful presentations and valuable expertise on management of complex situations in cataract surgery. Special thanks to our VOS faculty, very own Shailesh and Manish. Excellent videos and wonderfully presented, and actually very good practical tips which they gave. Equally thankful to all the chairpersons, moderators, and panelists for taking out time from their schedules for this webinar. Special thanks to Team Buldhana Ophthalmic Surgeons Society under leadership of Dr. Surekha ma'am and Dr. Dhaki sir for collaborating with VOS for this informative webinar. And a sincere thanks to Entot Pharmaceuticals and the technical team for their generous support and collaboration in making this event possible. Lastly, I'd like to thank all the attendees for taking out time for this webinar and making it a success. Thank you once again, everyone. And please block the dates for the 50th annual conference of the VOS to be held at Nagpur on 10th and 11th of January, 2026. Thank you. Over to you, Rahul.
Yeah. Thank you, sir.
Thank
So
you.
here,
So
thank you,
before we
Deepak
wind,
sir. Yeah.
before we wind up, I would like to congratulate Dr. Deepak Megur sir for the silver button of YouTube that he has achieved by crossing 1 lakh subscribers. Congratulations, sir.
Congratulations.
Congratulations, sir.
Thank you. Thank you.
Congratulations, sir.
Thank you. Thank you.
Yes, sir.
Thank you.
Yes, sir.
Thank you. Good night.
We'll
Thank you. Thank you, everyone.
Thank you, everyone.
Good night.
Good night, sir. Thank you.
good
ma'am.
night.
Good night. Thank you.